Thank you for the opportunity to present our work. The MACE procedure, first described in 1990, allows for colonic irrigation for management of fecal incontinence, typically in the pediatric population. Over the years, there have been various modifications in an attempt to decrease complications and improve outcomes. This procedure was first described laparoscopically in 1994. The placement has been moved around, and some people now do this percutaneously. All of these surgical technique changes were to improve the outcomes, and other things we've done to try to improve outcomes and decrease complications are changes in postoperative care and follow-up. But newer evidence in different fields suggests that multidisciplinary teams may improve surgical outcomes. This has been shown in the inpatient setting, but has not yet been shown in the outpatient setting. And so we hypothesized that implementation of a multidisciplinary colorectal clinic would improve surgical MACE outcomes. We sought to evaluate outcomes and complications, including stomal stenosis, stomal leakage, and reoperation. Our multidisciplinary colorectal clinic serves as a patient-centered home where patients undergoing MACE procedures are receiving the majority of their care. We undertook a single institution retrospective review looking at the 1 year before and 1 year after implementation of this multidisciplinary clinic, which was in 2011. We sought to look at patient factors, surgical variables, and their postoperative course. Patient characteristics were largely the same, and surgical variables were also very similar, though we do see that after the implementation of clinic, there was an increase in patients undergoing imbrication of the cecum over the appendix as an additional continence mechanism. We didn't see any difference in stomal complications looking at infections, granulation tissue, stomal leakage, or stenosis. And we also didn't see any difference in reoperations, though if you see there's very small numbers on both sides. So we thought that we should expand our cohort. And so rather than looking at just 1 year before and 1 year after, we looked at the 2 preceding and after years. And again, didn't see any difference in complications or unscheduled follow-up to the ER or to clinic. And reoperations again were very similar. So we didn't see in this case that there was any difference in surgical outcomes, but something that we found was that patients who were followed in this multidisciplinary clinic with advanced practice providers had many more phone visits so that they were able to manage their bowel program over the phone rather than having to come in. And there was no difference in the number of clinic visits, so we would estimate that the cost of care should be similar, though we don't have this data. So we didn't see any difference in stomal complications or reoperations. And if we think of reoperations being necessitated by surgical technique, this makes sense. But we did see an increase in phone follow-up with the implementation of this multidisciplinary clinic, and further work will show us if this is impacting patient and family satisfaction. Thank you.
Bill Gibson again, University of Alberta. These are complicated and very challenging patients. How on earth were you managing without a multidisciplinary clinic? It seems frankly insane.
Well, they're done by lots of different people. So some of the patients were followed in spina bifida clinic. They were operated by urology. But a lot of the patients who were operated on by general surgery or pediatric surgery actually didn't. And so we thought that we would see differences in their outcomes afterwards. And I think that we are seeing differences in sort of satisfaction and how dry or clean they are. But in terms of surgical complications, it actually doesn't matter, right? Because I think that probably depends on how you do your surgery.
Any other questions?
Great. Thank you.